I would like to invite Dr. Omar Ayub. Dr. Omar is a neurologist at King Abdulaziz University, and he's going to talk to us about hypertension and central nervous system. Please, Dr. Omar.
Assalamu alaikum wa rahmatullah. First, I'd like to thank the organizing committee for the invitation, and I thank everybody who stayed late in the conference. It's 4 o'clock, and you should be at home by now, but thank you for staying to the lectures. I was giving the topic to speak about hypertension and its association with CNS disorders. And I think if I spend 20 minutes in that topic, it's not going to give any fair neither to the topic itself and neither to you. I would like to be very concise. I have chosen one of the topics of neurological disorders and hypertension, which is important, and I took the controversial part of the acute stroke and hypertension rather than long-term management of hypertension and stroke. So all what you will see are the data for patients who are presenting with acute stroke, and what are we going to do with their treatment. Shall we stop it? Shall we continue treatment? And what are the medications that we should start? How are we going to tackle the exact numbers, if there are any? But we'll see how this will go. So the epidemiology, you're all aware of, the stroke affects about 15 million people around the globe. It used to be the third leading cause of disability, but recently it has been upgraded to the second leading cause of death. It is the leading cause of disability. It used to be the third, and now it's the second leading cause of death after cardiovascular disorders. Blood pressure or high BP is also one of the important and leading modifiable risk factors that we need to target on the long term in patients with stroke. About 75% in some papers of patients who are presenting with stroke have high blood pressure. Some of them may have low blood pressure, but the majority, they have high. We have the concept that blood pressure falls in the acute period. So if someone presents with high blood pressure during the acute stroke, in the, let's say, 180, 170, it will fall spontaneously. But should we wait for that fall? Should we wait 1 day, 2 days, 3 days, 5 days, 1 week, 2 weeks? We actually don't know until now. The most important concept in the whole treatment of acute stroke that you need to understand, and I think most of the trials have been swayed by that concept. All what we do in acute stroke in terms of acute thrombolysis, thrombectomy, it all depends on the concept of the core and the penumbra. So you have to understand that very well. One of the things that I need also to share with you is that the treatment of acute stroke in terms of thrombolysis has changed significantly over the years. We used to think of acute stroke to be treated by thrombolytic within 3 hours. That has changed over the years to be 4.5 hours. In the recent World Congress of Stroke, they have published or released the information on the trial, extended trial, where we can now thrombolyze patients up to 9 hours. So that is going to come. It is not a guideline yet, but it will change. The concept of time treatment has already vanished from the literature. We already now depend on tissue-based treatment. So patients who have viable tissue will be treated with either thrombolysis as IV or thrombectomies. And the same thing applies to hypertension. So hypertension, you can see the differences in my talk about the outcomes in many of the subclasses of antihypertensives. It's mainly depending on that penumbra. So if you have someone who is presenting with, let's say, an MCA stroke, the first circle, which is the dark one, it's already gone. So someone who presents with right-sided weakness and aphasia, okay, we may see the manifestations because of the stunned tissue of the penumbra. So the amount of potential stroke, that is the penumbra, is making the patient symptomatic. But what is the final outcome of the patient, whether he is going to go into complete hemiplegia or complete hemiplegia and aphasia with a visual field loss, is depending if you can save that penumbra and leave him with a small core. So if you maintain proper perfusion of the brain, either by maintaining high blood pressure during the acute period or opening that vessel, this will ensure that those areas who are still not dead yet will be saved. On the right-hand side of the figure, you can see that we have different things or different tests that we do to say, oh, this tissue is in the penumbra phase, or this tissue is already dead. The most important of which is CT perfusion. And that's what we usually do in our university hospital. If someone presents within the acute period, we do straight CT angiogram, and then we do CT perfusion. If that patient, no matter what is the time factor of his presentation, will be treated according to the CT perfusion if he had an area to save. And the same thing happened here. You can start up with a red area that is very small at the beginning, with a green area that you could save if you treat the patient appropriately by thrombolytic, and also if you treat the blood pressure appropriately. That area will get bigger and bigger and bigger if you don't do all what we can do to save the brain tissue. That's the image of the perfusion pressure. All what it says is that we have cerebral volume and transit time or flow. So if you have a prolongation in the flow in certain areas of the brain with preserved volume, that means that area is not dead yet. But if you have high volume with high or impaired cerebral blood flow, that means it's a dead tissue. And that's the way that we look at CT perfusion to know that these are the areas that we need to save. It's been well known that there is a U-shape. If you want to remember anything from my lecture with hypertension and acute stroke, there is a U-shape relationship between acute stroke and hypertension. So if you lower the blood pressure extensively, to a very low period, low levels, which is, it's around less than 140. And if it is more than 160 or 180, this is detrimental to the brain during the acute period. So your plan is to keep that blood pressure in the acute phase within 140 to 60. And that's the usual figure I always tell my residents. Keep it between 140 and 160. This is safe. Forget everything else, despite the guidelines. So from the acute stroke trials, we know that the pulse pressure, the variability in the systolic blood pressure, the MAP, all of them, they can have poor functional outcome in association with a stroke. We have multiple reasons why those patients with acute stroke might have a hypertensive episode. Namely, they might have infection, they might have hypertension, they might have pain, stress. So there are too many things that are a big player to the elevation of hypertension. The autoregulation of the brain is still impaired during the acute stroke, and that will make the perfusion to the brain dependent mainly on your MAP, or the cerebral perfusion is dependent on the MAP. So if you have rapid elevation or rapid deterioration of blood pressure during the acute phase, that will be also detrimental. So what were the trials that looked at blood pressure? Multiple. I'm not going to go over them in details. All what I was going to say is that, let's say one of the earliest trials was the CATIS, which is a Chinese trial, involved about 4,000 people. When they give different kinds of medications, they could achieve the lowering of the blood pressure. But at the end, when they looked at the primary outcome, which is the modified Rankin scale more than or equal 3 at 14 days of discharge, the results were neutral. So there was no benefit of reducing the blood pressure during the acute stroke. They looked at the Chloridine. It was a small trial, never have done it in the longer trials, and we can't have any suggestion that we can use Chloridine during the acute period of the stroke. What about ACE inhibitors? Initially, they looked at 3 small trials. They were feasibility trials looking at hypertension and acute stroke. They figured that probably there is an improvement in the NIH stroke scale, but overall there was no difference in the outcome as measured by the modified Rankin scale or even the scores in the NIH. They said, okay, let's do another trial, which is the CHIPS trial, 179 patients with either ischemic or hemorrhagic stroke within 36 hours and with hypertension. They were given either oral treatment or IV, depending if you can ingest medications or not. And they were escalating the medications according to the response. And eventually what they said is that lisinopril that they use in the CHIPS, they reduced the blood pressure appropriately, but there was no differences in the functional outcome. Then came the other trial, which is the pill fast. The same thing. They randomized people within 3 hours, and they looked at lisinopril versus placebo. They could also decrease the blood pressure. That trial also was negative. Then they shift gears to the ARBs, or the ARA, or the angiotensin receptor antagonists. And they have looked at it in multiple trials, which is the AXIS, the subgroup of the PROPHES, and the SCAST as well. What they have found is that probably the ARBs in the acute phase of the stroke is not only neutral and can be actually detrimental to the use during the acute period. Nobody knows exactly why does this happen, but we don't have good outcomes with the ARBs. Beta blockers, it has multiple, there had been also multiple opinions about beta blocker use during the acute phase. Some of them, they were said, please use it. Some of them said, don't use it. But overall, still, the outcomes in most of the trials during the acute period are neutral. There is no effect on overall outcome. Calcium channel blockers had been assessed at the INWEST, where they had looked at to use calcium channel blocker in acute stroke within the first 24 hours. They were randomized to IV nimodipine as an infusion or an IV, either to 1 milligram or 2 milligrams for 5 days, and then 120 milligram orally for a continuation of 21 days. They stopped the recruitment because of the unfavorable outcome, which was measured also by the Barthel index, which is one of the measures for outcome in patients with acute stroke. Again, calcium channel blocker wasn't really very attractive in the use. They have conducted a further trial with the use of oral nimodipine, and that trial was stopped because there was a publication of a Cochrane review of 7,665 patients from 29 trials, which showed no treatment effect on functional outcome or death if you use calcium channel antagonists. Diuretic has the same thing. They looked at magnesium during the period of ultra-early timing of acute stroke or during the acute stroke in the hospitalization, and it was also 50-50 outcome. Same thing with nitric oxide. So after looking at all of these trials and all of these data on multiple classes of antihypertensive medications during an acute stroke, we eventually say we don't know. That's, I think, the better term of saying that we have done too many trials and we couldn't reach a proper outcome that we have thought that they are going to be effective. I think part of the reason is that we are collecting all types of strokes together. And I think because of the differences in the timing that we are giving the medications, some of them given within the first 6 hours, some of them given in the first 24 hours, some of them given within the first 3 days, there was discrepancy in all of these trials. We cannot really lump all strokes together. There is major differences between the pathophysiology of acute stroke in a large vessel disease versus small vessel disease, and you can't also lump these together. I think the pathophysiology and also the mechanism of the stroke in both are different, because if you are going to look at only large vessel disease, I always say, please don't drop blood pressure in large vessel disease. If someone has, let's say, ICA stenosis or IC block or MCA stroke, I keep blood pressure high, just leave it, unless I'm going to thrombolyze. And that's also being translated into the guidelines. So the current guideline says, during the acute period, which may extend up to a week or 2 weeks, don't drop blood pressure significantly. Leave it, even if it is scary, which is 220 or over 120. Leave that blood pressure. Don't treat it unless there is end organ damage, like acute injury, kidney injury, if there is any aortic dissection, cardiac ischemia, encephalopathy, or pulmonary edema. That is a totally different game plan. But for someone who has only acute stroke, don't drop blood pressure. And if you want to drop blood pressure because of the nurses is bugging you, drop it by a maximum of 20% during the acute period, and that's about it. Should we keep the antihypertensives or we should not? I think it's up to you. It's been also controversial in the literature. When someone comes during the acute phase and they had been on medications, should we leave it? Should we leave the antihypertensive or should we stop it? I think the jury is not out, and I think do whatever you want as long as you are keeping the blood pressure within your limits. But if you are going to treat those patients, we have standard guidelines. So for the TPA, for the thrombolysis, if you are going to give that patient thrombolysis, blood pressure has to be less than 185 over 110. And that's a guideline. It's been agreed upon. Unfortunately, to tell you the truth, that recommendation was based on expert opinion. It wasn't actually on a randomized control trials, but it was working beautifully in most of the IV thrombolytic trials and also for the thrombectomy trials. After you treat those patients, then your digits for the blood pressure has to be lower. So this is one of the few things in acute stroke that is agreed upon, is that if you are going to treat patients with thrombolysis, keep blood pressure less than 180 over 105. They looked at the SITS registry, which is one of the largest registries in the globe, and they have looked at those patients who had been treated with thrombolysis and then with high blood pressure, and they said that higher blood pressure during thrombolysis that does not follow the guideline, it was associated with poor outcome and also increased mortality. So that was a support that we should treat hypertension during the either pre-thrombolysis or post-thrombolysis. Otherwise, leave blood pressure rise wherever you want it. And this is the latest guideline. It was updated in 2018. It is summarizing exactly of what I was saying in the last trials. One of the things I need you just to remember, these are the newest trials, which is the 5 trials of the thrombectomy that we have that have changed the treatment of acute strokes and large vessel occlusions. I have too many other slides. I think I'm going to skip them for the sake of time. Do I have time? 1 minute? No, خلاص, enough. Because I have few slides about treatment with large vessel disease, also bilateral carotid stenosis. I have treatment of ICH, but I think I'm going to skip that and leave it for further questions if you have. Thank you very much.